Perfect. Hi, I'm Grant Garrigues. I'm the co-chair of the AAOS Shoulder and Elbow Registry. Very excited to be talking to you about the importance of registry data, and specifically, if you're doing shoulder surgery out there, why you should really look long and hard about being a part of the Shoulder and Elbow Registry. I practice in Chicago at Midwest Orthopaedics at Rush, and I'm a proud member of the AAOS as well as the ASCS and multiple other shoulder-related societies. Very excited to talk to you about this today.
All right. Hey, Dr. Garrigues, how are you?
Good.
Good, good. Well, I appreciate you joining here today to talk about the Shoulder and Elbow Registry hosted by AAOS. Really wanted to kind of get your perspective of being the chair of the Shoulder and Elbow Registry and some of the benefits that you foresee in that registry.
Absolutely. So it's been a real honor being the chair of the Shoulder and Elbow Registry. First being a member and the ASES representative to the SER, and then the chair. We have a great committee, people that have worked really hard, both the internal AAOS employees and the different representatives from all the relevant societies. So you can imagine there's a lot of people that do shoulder surgery. So AOSSM, ASCS, ANA, Hand Society, they all have representatives involved in the creation and maintenance of the registry. So it's been a real honor serving with all of them, and I feel proud of the work that this team has accomplished.
Yeah, it's registry are definitely growing over the last couple of years here. Um, in the registry itself, so how do you foresee registries change from the past, like a couple of years ago, even prior to your life at Rush at Duke? How have you seen registries change from in the past to the present today?
Sure. I mean, in the last few decades, right, big data has become the thing. And now with AI and machine learning and an increased ability to mine that big data and make useful conclusions out of it, I mean, it's just totally, I think, proven the case that as we get larger numbers, we can make more meaningful
Mhm.
and richer conclusions. I mean, it wasn't so long ago that um, prominent people in our field were saying that big data was like a sausage and you don't know what's in there. And I think people have moved past that as the data level of sophistication has improved to
Mhm.
now people are really seeing the value of these large databases, especially if they're well curated and the data integrity is high.
Mhm.
Certainly, the shoulder and elbow registry of the AAOS is one of those. So I think the questions being asked are important. We're seeing this internationally, so
Mhm.
I think some huge opportunities are obviously U.S. large diverse country. It's a little harder to do registry than some of these smaller, less diverse countries with a single payer system.
Mhm.
But that doesn't mean it's not a worthwhile endeavor. And I think having our registry and then being able to compare that and work with our colleagues in other parts of the world to benchmark not only in our own country, our own community, but around the world where different techniques or implant systems may be used. I mean, really can provide a lot of value to patients. So the value of this is both to the members to understand where they stand and also to the patients. And I think the value is really limitless.
Yeah, and you kind of touched on a couple pieces there around the US and some of the payer markets here. How do you foresee that changing in the future as I look at some of the other registries where payers are starting to look at from a value-based care standpoint, the participation within those registries for those accreditations or centers of excellence.
Absolutely, Sean, you nailed it. So payers are wanting to now see exactly that you're involved in this sort of process improvement, registry data collection, et cetera. And so for many payers, any small costs related to the registry are largely or completely offset by the synergies that you're getting from those payer contracts. So very much that's great. Honestly, it's hard for me to say that some of the insurance companies are doing is a positive thing, but I think this is actually they're incentivizing some behavior that's both good for the system in terms of doing the right thing and also good for the patients.
Yeah, couldn't agree anymore. Regarding the registry itself, so you have kind of two fields of data collection within the registry itself. You have your required fields such as the the patient, excuse me. You have two fields that are required. There is procedure data, that you collect, throughout your procedures. And then there's also the PRO data. What type of value do you see in collecting one, the procedure data, as you alluded to, comparing and contrasting different types of methods of doing those procedures, but then linking it to the patient-reported outcomes data to amplify the patient's voice and ultimately understand from their perspective of how they're recovering?
Sure. So I think great question. I think taking the procedure data is important because obviously you want to know just general trends. How are surgeons using in the real world implants for certain conditions? Are they using them on label, off label? Are they using them for this scenario or that scenario? What kind of patients are getting these implants? Does it vary from region to region? What are the trends, right? What procedures are more popular, less popular? So you can ask some very broad level questions. The next thing about that implant data is how do they fare over time, right? So as we've been able to link this with the CMS registry, we can now look, and so if someone has a revision, we'll know that how long these implants are lasting in situ, which is incredibly impactful. And then if you drill down to, hey, this patient had this implant, this particular type of implant for this procedure, how long did it last, and how did that fare versus others? So that's super helpful for physicians,
Mm-hmm.
helpful for patients, and helpful, frankly, for industry colleagues in terms of which implants are working better than others and how to improve that over time. However, all that's to say that it's not just about the implant lasting and what the revision-free survival of the implant is. It's about function, right? It's about pain relief. It's about these are not implants in a vacuum. They're in a real patient, right? So the patient-reported outcomes really, link that to, define patient metrics that we all care about. That's what is meaningful to us. So part of it is, revision rate, longevity of the implant, but part of it is pain, function, and patient satisfaction. So you really need both pieces of this to tell the complete story.
Yeah, and then on that story here, when you have both sets of those data, how do you see that being valuable in such as, like, say, for instance, the care setting, in talking with the patient?
So my partner Greg Nicholson, he has this great quote. He's what patients and physicians want is predictability, right? They want to know when they're signed up for the surgery, how long is this going to last? What's my range of motion going to be? Am I going to be happy? Is my pain going to be gone? And they don't want the answer, well, probably, maybe, if you're lucky. They want to know, right? What are my chances of this? What are my chances of that? And I think, having this kind of information, we can really tell that story to the patient and with some degree of, assurance that, hey, if you have this implant for this indication, you have these comorbidities, you can have 95% reassurance that it's going to last you X number of years. I mean, that's what patients want, right? And that'll help you make real world decisions as a physician, but also the patient understand what they're getting and what they're gonna know. It's just like if you have a car, you want to know, what's that warranty? We don't have warranties for implants, but at least we can give them some sense or some reassurance for how long these things are going to last and how their function and pain is going to be affected.
So how do you foresee the AAOS registry and shoulder elbow registry in particular supporting yourself in registry initiatives and the outcome studies that you're doing today?
Right. So there's different phases of this, and setting up a registry is not like just having a little Excel table of your patients you've operated on. The first step, right, is defining all the data fields and collecting the data, and that's been going on. That started before my time. People like Jerry Williams, Joaquin Sanchez Sotelo, and others have really kind of laid the groundwork for picking the data fields and getting registry data into the system. Right. The next step is the data fidelity stage, and that's kind of what we've sort of kicked off under my tenure. And that's really spot checking, deep diving, going into these different data fields and trying to make sure that what you're seeing as far as, hey, this patient had a revision on this date, or this patient's implant was working well for this period of time. Is that true? So actually pull the actual charts and make sure that you can trust the data that you're getting. And that's kind of where we're at then. And then is when the really fun part starts, because then you can ask all kinds of questions like we talked about earlier about, I mean, the big one in our field right now in shoulder and elbow is for primary glenohumeral osteoarthritis. is the anatomic total shoulder still the gold standard, or is it the reverse total shoulder, right? So I'm a big fan of the anatomic total shoulder. I think the best anatomics always better than the best reverse, but it has the potential complication of glenoid loosening, whereas the reverse has the potential complication of instability and stress fracture. So it's different complications.
Mhm.
They occur at different time points, some early, some late. Obviously, the data we have is from implants that are 10, 15 years ago. So being able, but however, we're still confronted, you know, many, many times every week with patients with this question, what implant should I choose for that patient?
Mhm.
And so right now, a lot of it is, trends, what you learn in fellowship, what the guy next to you is using,
Yeah.
right? What the patient is asking for based on direct to patient marketing. We need to have some real data informing those decisions about what is the best for that patient. And that's where the registry is really going to, in the next phase, help us answer those type of really critical questions.
Yeah, it kind of led me right into my next question. As the chair of the Shoulder and Elbow Registry, what do you see the future of the Shoulder and Elbow Registry, 2 years, 5 years, 10 years from now?
I see that, this is kind of like a snowball, right? The more that you kind of get it started, and as it grows and grows and grows, and then it becomes just absolutely something that everybody at this point already should want to be a part of, because I mean, this is kind of the exciting time to get involved. And simple things like just knowing where you stand for benchmarking as a physician versus other physicians, right? I think that's helpful for our own quality assurance and quality improvement. But then also, relevant patient questions from a more broader perspective about, the right indications, what's the best thing to choose for my particular patient. So the questions we can ask are really quite extensive, and the
Mhm.
complexity of those will only grow as we get more data and more long-term data into this registry. So I think the future is very bright.
Mhm.
I think if you're doing, yeah. So I would leave everybody with this. I would say E.A. Codman, right, the father of American shoulder surgery, had this idea called the end result idea. And it was the idea that he said that every patient should be followed until they reach a steady state. So at the time where he was practicing, at the beginning of the 20th century, that wasn't the case. Physicians would do surgery and hey, there's your, take your cash in the barrel head and good luck, right? There wasn't a lot of there was no follow up, right? And there was no, and so the physicians never knew if the things they were doing were actually impactful in a positive way or neutral
Mhm.
or even a negative way. And E.A. Codman said, no, no, we need to follow every patient to a steady state. He actually had a small private hospital. He wrote a whole book about every patient that was in his hospital and how they did and what interventions were. Long story short, he obviously, or you may know, was kicked out of the Massachusetts Medical Society, kicked off the MGH faculty, died penniless in an unmarked grave for this crazy idea that we should follow our patients. And I think the time that has elapsed has shown us that he was absolutely right. He was ahead of his time in so many ways.
Mhm.
And I think just to succinctly say, I think this is really kind of the fulfillment of his vision is that we should follow our patients. We should see how our procedures are doing. And as physicians, we all already have that onus on us, but this is the
Mhm.
ultimate expression and way to do that is being a part of the AAOS shoulder and elbow registry.
Yeah, that's very well said. So, last thing I would ask you here is, and you kind of alluded to in some of that statement there, if if you're doing if you're a shoulder surgeon today and you're not participating in the shoulder and elbow registry, what is kind of the three main reasons why you should participate going forward?
I mean, for yourself, for your patients, and for your community. I mean, like you need to know where you stand, what's working, what's not working. And you may think but you don't really know unless you look at the data. And we say what gets measured gets improved, right? And if you're not following your patients in that way, you don't know, and you don't know how you benchmark with others. And for your patients, I think patients are starting to demand this. I mean, they're asking these
Mhm.
questions,
Yeah.
and to be able to tell them, hey, this is your chances of success, good, bad, or otherwise. And for your community, I just mentioned that this is really impactful for our field as a whole. if we don't do this, quite honestly, like government institutions are going to step in and try to police this. And I think we all agree as physicians that we should be in charge of these types of efforts. And so I think supporting the AAOS and their work in this field, and frankly, their record of success with the hip and knee, the AJR registry. I mean, this they have done this, they are doing this, and they will do this. So I think supporting this so that someone that's not on our side and not on our team is running this. I think we, as the AOS members, should be running this. I think, the last thing is, the how, right? Hey, maybe you're watching this video, you're excited about this. What do I do? You need to go to your hospital administrators. I'm sure we'll put some links about how to get in touch with the AOS, but there's a lot of value for the hospital too. So I know anytime you go to a hospital administrator, it's more work on their plate. It's a little bit of an uphill battle. And are you willing to fight that battle as a surgeon? Well, you should be because A, it's going to help you. It's going to help your patients. It's also going to help the hospital in a broader sense. We mentioned some of the insurance contracting and the improvement measures and the metrics that you can get credit for that. So, definitely would encourage you to get in touch with the academy. They have fantastic liaisons that can just take it and run with it and work with your institution and come up with a plan to get you involved in the registry. And obviously, we'd all like each and every surgeon doing a shoulder and elbow surgery, whether they're shoulder and elbow trained, sports trained, hand trained, generalist. If you're doing these surgeries, you should strongly consider being a part of this registry.
It's interesting. I was just at a conference this past weekend, and that was actually a big talk track around controlling the narrative from the surgeon standpoint. So, as these government bodies or regulations are coming in to kind of demand this next step, is getting ahead of that game and being, again, controlling the narrative, whether or not it's from a coding standpoint where like systems are starting and pairs are starting to leverage AI. Well, if you as a surgeon, you make your own fate when you are doing your procedures, but then collecting that data to represent the care that you're providing and the quality of care that you're also providing.
That's right. And I think again, you can make claims, but you have to have data to back up those claims. And so, for example, if your health system is says, "Oh, we're a high volume center," well, it's going to mean a lot more when you're talking to patients saying, "Hey, we're in the top 10th percentile of people
Mhm.
doing this," right? Or we get great outcomes, right? You're going to want to know that for yourself, and also your patients are going to want to know that as well. So I think there's so many benefits to this. You've seen the number of cases going in has been skyrocketing. So many people are finding this benefit, and so yeah, get on the bandwagon, become part of the excitement.
Do you foresee so over the last year, shoulder surgeries have been approved for the ASCs? How do you foresee some of this outcome data coming into that space too as well to kind of reflect now shoulder surgery? So excuse me, shoulder surgeries moving into the ASC setting.
I think we have to do it because, as you said, a lot of them are being done in the ASC. I mean, I've done a lot of research in that personally, showing that that's cost effective, safe, and lower cost to the system. However, registry data at a high level quality registry is really the gold standard. So we need to show, is that really the case? And more importantly, what patients are appropriate, right, for that, and who is not, right? We need to match the appropriate patient to the appropriate setting. And I think having high quality data like registry data will help us make those conclusions. We have some registry calculators. Other teams have come up with those, but that's based on single institution or two institution data. I mean, really looking at the whole, universe of shoulder surgery and being able to tell a patient, no, you should not do this because your risk is too high, or yes, you should. Your risk is extremely low. You should go there. I think is going to be the next venue for this.